Thanks for having me. Came in from Ann Arbor this morning. You can blame the weather on me if you like. It looked exactly like this morning when I left. I have nothing to disclose. Nobody pays me except the University of Michigan, and the only relationship I have is with my wife. Learning objectives. I'm going to discuss some challenges in the appropriate delivery of preventative health care to men. So as a family physician, this is what I do. This is what I should be doing, and I need to be successful at it. We need to understand the construct of how men view their health care, and I think Wayne's lecture was a perfect lead-in to what I'm going to capitalize on here. I'm going to highlight some evidence-based screening guidelines according to United States Preventative Services Task Force as well as other societies. And then we're going to talk about how to effectively counsel men and get their attention, keep them healthy. So for an overview, male gender is an important determinant of public health in the US, Europe, and worldwide. We know that. We know that health across a lot of the nations is very poor. Many disparities exist between men and women, and there's few health initiatives and research operatives that have really addressed this adequately. So for example, National Institute of Health, NIH, funds $0 in terms of men's health. That's not to leave out urology and prostate cancer, but specifically for preventative men's health, it's $0. For women's health, it's in the billions. We know discrepancies in health issues between men and women can't be explained solely by biologic differences, but these play a critical role. There's a lot of factors that influence health decision making, and the global healthcare community must be willing to impact this and change outcomes. So, rewind the tape about a decade ago. I got real manic one weekend and said, you know, there's no men's health textbook. I'm gonna do this textbook kind of a thing. I thought I was going to bang it out in about a weekend. I didn't realize it was going to be a little bit more work than that. But I started and I figured, okay, where to start better than my own practice? So I asked one of my patients, what is men's health? And he said, you know, guy problems, you know, prostate issues, genital issues. Men die of heart attacks and strokes. Maybe they go to the gym. They get cancer. They take stupid, risky behaviors, and guys like to take chances. They don't always think about what might happen. They should know better. Should probably about cover it. And so while this is all important and relevant, it really only scratches the surface. I do a lot of work in the media. I was asked a few years ago by Fox to give a sort of capitulation on what I thought men's health was. Thought, okay, media, I'll try not to swear, I'll try to be professional kind of a thing. I said, men go to the doctor, because they have questions. Just try to sound very, professional and intuitive. And one of my colleagues decided he was going to upstage me, okay? But this is very important because below the belt issues are often what get men to go to the doctor in the first place. So I'll never be professional in any media interview ever again because I want top billing now. This is designed to be rhetorical. The women in the audience certainly don't have to answer this, but is being a man a disease? What does all this mean? So data from a few years ago showed that the potential years of life lost for men under 70 in the European Union was about 6,000 per 100,000. It's twice what it was for women. So is being a man dangerous in and of itself? Again, back to Wayne's excellent lecture, there were a lot of points there that are relevant. Can something be done actually to improve the life expectancy of a man? So if you look at some of the countries in Africa, the discrepancy is by more than 10 years. If you look at Estonia and Latvia, which have the lowest life expectancies for men outside of Africa, the discrepancy is almost 20 years. Okay? Will we see the gap in life expectancy widen while gaps in social determinants become narrower? And what are the effective, morally acceptable strategies to address these and work with men to modify potentially harmful and negative behaviors? It's been estimated through the European Men's Health Report that about 50% of male deaths could be prevented. 50%. That's pretty staggering, right? Men remain uninformed about their health issues, take a lot of risks. They're reluctant to seek medical care. We know this. And a lot of male-related health problems can be detected and treated at an earlier stage with greatest awareness, right? The biggest reason I got into medicine was to be a teacher. It's probably the biggest thing I can do in any patient visit, right? If a patient walks out of the room, they don't understand what happened. They can't leave and go home and modify what they do or understand what they do. We haven't succeeded as clinicians, right? Men are at an age-adjusted greater risk of premature death than women for all causes that you would think would affect men and women equally, but they necessarily don't. And there are poorly understood biologic differences. So, sorry to have to bring you back to, school level here, but I want you to memorize this slide, and I'll tell you why in a minute. What gets women to the doctor? This is a Gallup poll from 2000. This will never be repeated. Okay, probably shouldn't be repeated. Nobody's going to spend the money on this. What gets women to the doctor? Routine health maintenance. Granted, I understand cervical cancer screening guidelines have changed. Followed by chronic health problems, urgent care, opportunity arises such as new job or new insurance, urging of spouse or significant other. So memorize that for a minute, okay? What do you notice? Does it shock you? It's exactly the opposite, right? It's amazing. I always look at my schedule in the computer, figure out why they're there, the patient's there, and I look on the sheets, they're outside the door, and I walk in, and it's amazing. I had one, it was Monday morning, first patient, 8 o'clock patient. Chief complaint, nagging wife. I'm serious. I didn't put that in his medical record, but nagging wife, that's what got him there. I said, okay, great, fine, I'll take it from here. So the Centers for Disease Control report that almost 160 million US males, right? Here are the stats. 1 in 8 over 18 consider themselves to be in fair or poor health. This hasn't changed in a decade. That stat has not changed in a decade, despite our efforts, okay? These are the rates for smoking. Interestingly enough, people are switching from tobacco to marijuana. Rates of marijuana smoking are going up. In Ann Arbor, it's about 312%, you know, is what's reported. Illicit drug use going up. 1 out of 3 men over 20 have high blood pressure, whether they know it or not, and 1/3 are obese, BMI, right? Michigan, 5th heaviest state in the country, 5th heaviest. Why don't men take better care of themselves? Well, 24% less likely to have visited a doctor within the last year. Again, society has sort of taught us women need to go to the doctor once a year to get checked, whatever that means. We don't know what that means. But if you ask anybody how often a woman should go to the doctor, they're going to say, about a year. So how often should a man go to the doctor? The answer is we don't even know. We don't. This has never been studied. It's never been evaluated. Okay? We know about 1 in 4 have not had their cholesterol checked. 28% likely to be hospitalized for CHF, more likely. 1 in 3 more likely to be hospitalized for long-term complications of chronic diseases like diabetes. And 1 in 4 more likely to be hospitalized for pneumonia that could have been prevented by immunization. So again, staggering statistics. I went to the Centers for Disease Control and Prevention about 2 weeks ago, and they have a nice page that didn't exist a few years ago on men's health. And I like this because it's a great leap forward in terms of education. It also gets men right where they are, okay? So, leading causes of death, we're going to care about that, right? It breaks down things into kids, gay and bisexual men's health, a lot of science and research here, African American men with HIV. There's a great video, I'm not going to play it due to time, on binge drinking, okay? So it's very educational. But again, you got to get men where they are and hit them with what is going to be relevant for them. I don't own a nail gun, but if I did, I'd probably look at nail gun safety, right? Just to make sure I was holding the damn thing right? And then, of course, they put this at the bottom of the thing, but erectile dysfunction, and, you know, what do you see here? 18 million males over age 20. That's going to get men's attention, right? What are the disparities? Many men don't want to go to the doctor. I don't do research in women's health, but I kind of have this belief, I don't think anybody wants to really go to the doctor, right? 70% report caring more about their cars than their own health, okay? Now we're seeing, and I'm going to talk about this in a few minutes, these carrot and stick incentives, okay? I saw patients Monday, Tuesday, Wednesday, Thursday this week. That had trained, we think, in half days. That ended up being 7 half days, 7 4-hour sessions. I would say half of my men came in with a form. Hi, I need you to fill this. Can you fill this out for me and sign it? It's due on the 31st, by the way. You know, why are you here? Well, you got to fill the form out. Okay, so what's on the form? Okay, great. Anything else you need? Fill the damn form out. They're going to raise my rates. Okay, I'll fill it up. Okay. So, are these more for the middle and upper class? Because we don't have things like this for Medicare and Medicaid. Right now in Michigan, 1 out of 7 people have Medicaid. Okay. There's no carrot and stick incentive or disincentive to necessarily get them there. There's a lack of resources for a lot of the minority populations and men in the lower socioeconomic classes. There's a lack of physicians that the public health data reports as with whom they could identify. What will the future primary care healthcare provider look like? This is a great question. We're in this rapid expansion phase in America. We're going to give 30 to 40 million people healthcare, and we've got to expand this. There's a lot of masculinity factors. I won't focus on this. Wayne did an excellent job with this, but there's reasons men don't go to the doctor. There's also reasons men don't always tell you everything when they are there. Okay? How many of you have ever gotten a phone call from a spouse or significant other when the man left the office and said, now you can't talk to them, but they can talk to you, right? Said, did he go over this? Did he tell you he snores and keeps me up all night? Anybody ever get those phone calls? Okay. And with the Affordable Care Act, the question is who's going to be accountable for health outcomes in men as well? I like this slide because I hate this slide. This slide hasn't changed in over a decade. You see the citation at the bottom from the American Journal of Public Health, 2003. Men have higher rates of all of these issues. Hasn't changed. Don't know if it will change, but it's still a major issue. How do we organize preventative health care in men? Well, this is a big challenge. To do it, and to do it right, takes time, it takes energy, and it takes time and energy to teach men about these things and to explain to them what is in store for them in terms of prevention. Your average man goes to the doctor for a reason. Might be form completion, which is almost always inadequate and almost always barely scratches the surface on what you need to cover with them for a health maintenance visit. Some men come in with knee pain, and then you realize, oh wow, we haven't checked your blood pressure in 10 years, or you're very obese. When's the last time you went to the doctor? So a lot of acute issues end up superseding the health maintenance issues that we need to cover as well. With electronic medical records, it's getting a little bit easier for us to be aware of and keep track of these issues in terms of preventative healthcare services. And a lot of the biopsychosocial differences between men and women put men at a disadvantage for addressing these sorts of things. So why don't we do better? Well, if you look at the guidelines from the United States Preventative Services Task Force, if a man goes to the doctor, a man above the age of 20 goes to the doctor for a physical, whatever that means, health maintenance examination, whatever you want to call it, right? You have to do 56 different things. How many of you took a really challenging course in your college or university? How many of you sat there for an hour and walked out and maybe remembered one thing? It's the same thing. It's the same thing, right? So we know that almost 8 hours per workday are required for physicians and healthcare providers to implement all these preventative services. The standardized healthcare system may help with this, but a lot of electronic medical records are actually making it more difficult, and there's data on that in terms of time consumption. This is a list, albeit a sort of a boilerplate list of a lot of what I try to cover with my men during a physical exam, okay? There's data. A lot of this data was done in my department, in Department of Family Medicine at Michigan. It takes the average healthcare provider 6 minutes to adequately address this line and this line only. And that's ironic because the evidence is fantastic for that, and there's very little debate, okay? So you can see how detailed a lot of this may ultimately be to cover for men. What's the accountability factor? This is a great question. This is becoming a lot more realistic for us, okay? I was told last week that I'm responsible for a panel of patients. I said, cool, panel. That's about 1,900 people. Okay. How many of them I know? I don't know. I don't know who I know and who I don't know. And your salary and your reimbursement for the hospital and your practice now are going to be tied to how well you take care of this panel of patients. I said, okay, cool. Fine. However, some people are non-compliant, some people miss appointments, some people don't take their medications. Man, I was crushed. I thought, man, I became a doctor. I finally get to write a script. I thought they went to the pharmacy and swallowed the pills. I thought everybody did that. Apparently not. Or what if they don't reach their outcome goals? What if they don't get to the blood pressure goal or the diabetic goal? What if they don't get that screening test? And our systems likely will not assess our knowledge or our empathy toward understanding differences in men. It won't value patient autonomy and decision-making and compliance, and it may not respect limitations. So again, back to Wayne's excellent presentation. He gave a case on a man who didn't want to do anything. In some ways we may have to respect that, although we try to educate them. Do a lot of motivational interviewing. I teach the sequence in our third-year clerkship for motivational interviewing. which is challenging, right? Because you want to honor patient autonomy, and it's hard because it's easy to look at somebody and say, you know you shouldn't smoke, you know you need to lose 45 pounds by next Monday, kind of a thing, right? And you have to understand what their motivations are, you have to understand where they're coming from, what their fears are, what they've tried, what they haven't tried, and help them establish realistic goals. Empowering them and encouraging optimism. A lot of people don't follow our goals or follow our advice because we can't get past step one. This is the hallmark of primary care. This is what we're good at, establishing rapport with people and setting agendas and goals and building confidence. Ever have a patient who came to you and said, I can't lose weight? Nobody's ever had that. I'm the only one. Okay. So why can't they lose weight? It's because they tried and didn't succeed, right? So we have to work with them on that. When we look at the evidence, what's the evidence behind what we're talking about? Men are at an age-adjusted greater risk of premature death compared to women for all causes that you would think may or may not affect them equally. Things like heart disease and various cancers that are not gender-specific. And there's good evidence for that. There's poor evidence to show that we understand the masculinity factors, but we should. And we need to understand how male socialization plays a role with this relative to their help-seeking behavior. We're doing great efforts in terms of targeting young men and bolstering educational efforts. Men's Health Week is a great stepping stone for that. To have people understand their healthcare needs better and how to utilize existing services. Read the patient-centered medical home model. This is that place where men go and understand that they can get their health and answer their questions and get their resources. We have to understand the challenges in access to healthcare and an unwillingness to undergo what men construe as an ordeal. Guy came in last week, Monday, it's been a long week, and I ordered a bunch of tests on him. Why? Because he was due for them. And he said, wow, this is a lot of work, doc. Yes, it is. Yes, it is a lot of work to try to promote good wellness and healthy behaviors. What are the take-home points? Again, you got to understand, man, you got to understand where they are coming from, what they want, how they respond. Spent an hour with a gentleman yesterday. Finally, at the end of the visit, I think now he's going to use his glucometer. I think. Maybe. I hope. Okay? In our country, again, United States Preventative Service Task Force is often the standard in primary care, but we do rely on a lot of other society-based guidelines, especially those from National Guideline Clearinghouse, which is international, includes multi-country guidelines. It's hard. It's a lot of work to stay current with a lot of these guidelines. They change. In the U.S. alone, in the last 15 months, so since the beginning of 2013, guidelines for prostate cancer, breast cancer, and cervical cancer screening have all changed just in the last 15 months. We utilize shared decision making. Easiest thing to do is to walk in the room and say, I'm going to screen you for this, this is what we're going to do. Well, we got to understand what people's fears and motivations are, and it's not always a one-size-fits-all model. We strive to educate and motivate male patients, empowering them to help make decisions and understand parameters for a healthy lifestyle. Thank you.